audience. First of all, I would like to thank you to join us today. Please let me introduce my PhD topic, which is the surgery of the pelvic organ prolapse and the female stress urinary incontinence. My name is Júlia, and I am a PhD student and a resident doctor at the Urology clinic. My mission is to reduce the complications of the surgical treatments, and my vision is to formulate recommendations for the following surgical treatments in terms of indication, contraindication, and patient selection. Here the list of one of my finished and my two ongoing projects. The first one is the safety and efficacy of the female pelvic organ prolapse vaginal surgeries with implants. 1 in 2 women over the age of 50 have a certain extent of pelvic organ prolapse, and around 11% of the women had a surgery for pelvic organ prolapse by the age of 80. And in many cases, an implant surgery is required to treat the condition, and with vaginal implants we can achieve an excellent anatomical correction. However, there are some complications. And the increasing number of the complications was the reason why FDA has issued several warnings regarding the safety of these surgeries, and several countries, including the USA, completely banned the use of vaginal implants. However, there were no general exploratory analyses, and the guidelines and the recommendations are different when to use or when to avoid the use of vaginal implants. This is why our aim was to compare the safety and efficacy of the female pelvic organ prolapse surgeries with versus without vaginal implants. The question is, are there any differences regarding the complication and the efficacy between the patients who undergo these surgeries? The population was the females who undergo pelvic organ plus vaginal surgeries. The intervention was the surgeries with implants compared to without implants, and the outcome was the complication and the efficacy. We found more than 20,000 articles, and finally 77 full texts were eligible for data extraction. We categorize the outcomes for complications, efficacy parameters, and we divide the complications for functional and non-functional ones. First, I would like to show the multivariate model analysis of the non-functional complications. We measure the outcome in odds ratio, and I would like to highlight the odds of erosion. The odds of erosion with vaginal implants, it's 14 times higher. And I would like to highlight also the bleeding, which is 1.5 times higher in the implant group. And we made the functional complications multivariate model analysis, and I would like to highlight the de novo stress urinary incontinence, which is higher in the implant group. And we performed also a multivariate model analysis in case of the anatomical complications. The anatomical success is 3.22 times higher in the vaginal implant surgeries. So it's an anatomically successful corrections with the implants. And we analyzed the reoperation due to complication rates, and in case of the randomized trial, the patient who get a vaginal implant during the surgery had more than 2 times higher chance to have a reoperation due to complication. But the reoperation due to recurrence. In case of the randomized trials, the patient without vaginal implants had a higher chance to have reoperation due to recurrence than without implants. It was a very extensive analysis of the complication with the high-quality studies on a large population, but there are some limitations, which was the rare events and the heterogeneity, which goes because of the different vaginal implant materials and the different vaginal compartments. To conclude our meta-analysis, pelvic organ prolapse surgeries with vaginal implants in more effective procedures, the reoperation due to complication is acceptably low, and the leading complication is erosion. For the practice, we should revise the vaginal implants, and we should feed the guideline for the daily practice. We should find the best target population where we can perform these kind of surgeries. For the research, we need more well-designed RCTs, and we should analyze the prognostic factor which predispose to complications. We published this article last year in a Divan journal. And our second project is the risk factors of vaginal wall erosion after an implant surgery. The background is similar to the first one, and this meta-analysis based on the first one, the leading complication was erosion, and now our aim was to identify the causes and the prognostic factors which predispose to vaginal wall erosion after a pelvic organ prolapse vaginal surgeries. The question is, what are the subpopulation of the women who shouldn't undergo the pelvic organ prolapse surgeries with these implants? We analyzed the females undergo pelvic organ prolapse vaginal surgeries with implants. The exposure was erosion compared to no erosion. The outcome was the risk factors. So our hypothesis is there are specific risk factors associated with erosive complications, and if we identify the potential risk factors, we can reduce the occurrence of erosion after these surgeries. We found more than 17,000 articles, and finally 36 full texts were eligible for data extraction. We analyzed the potential risk factors, and we find a higher chance of vaginal wall erosion in case of smoking, concomitant hysterectomy, and postoperative hematoma. And we hypothesized that concomitant hysterectomy linked to erosive complications. We compare erosion group and the patients without erosion. And in case of the concomitant hysterectomy were performed parallel with the prolapse surgery, the patient has more than 3 times higher chance to have an erosion. In case of smoking habits, we analyze the smokers versus non-smokers, and the erosion was occur in a higher chance in case of the patient has a smoking in the anamnesis. And in case of postoperative hematomas, we only have 2 articles. This is why it will be only the systematic review part, not in the meta-analysis. But it's very important complication, and it's pretty homogeneous. In case of the patient had a postoperative hematoma after a surgery, the erosion had a higher chance, a double chance after the surgery. In case of the sexual activity, we don't find a statistically significant difference in case of the erosion and the no erosion group. However, it's a very important factor which can predispose to vaginal wall erosion. But maybe there are a co-founder factor which has effect to the woman in the sexual activity. It could be the dose of the sexual activity. And yeah, we are on the manuscript writing phase, and we hope we can submit this article soon. The third topic is investigating the risk factors associated with complications of female stress urinary incontinence with sling surgeries. The prevalence of the female urinary incontinence varies 11 to 60%. The majority of the cases is stress urinary incontinence. And FDA has issued several warnings, not only for the pelvic organ prolapse vaginal sling surgeries, but also the stress urinary sling surgeries. And some countries partially limited the use of vaginal slings. However, the guidelines still recommend to use the subourethral sling surgeries in case of stress urinary incontinence. This is where our aim was to identify the causes and the prognostic factors predisposing to complications of the female stress urinary surgeries with synthetic slings. The question was, what are the risk factors which can influence the complications associated with females after the synthetic sling surgeries. The population was the females who undergo synthetic sling surgeries. We analyzed the risk factors, and the outcome was the complication rate. We hypothesized that the mid-urethral sling surgeries are still safe and effective to treat the female stress urinary incontinence, and there is correlation between the risk factors and the complications. And we use the population and the intervention in the search key, and now we ready to submit the protocol into the Prospero. And To summarize my project, I have one accepted article about the safety and efficacy of the vaginal prolapse surgeries with implants. We are analyze the risk factors of the pelvic organ prolapse surgeries, and we would like to submit in this year, and we would like to investigate the risk factors of the stress urinary incontinence surgeries. We take part with the topics in many conferences, and I do many additional sports activities, not only in the water, but also in the air. And I would like to say thank you with this quote from Rolling Stones. You can't always get what you want, but if you try sometimes, well, you just might find you get what you need. Thank you.
David Sandashkovic. May I ask you in which subpopulation do you recommend this vaginal implants, and in case of POP?
Yeah. Please let me turn the question when totally not recommend to use vaginal implants. In case of first line, in case of the patient it's very old, in case of the patient it's very young and has a sexual activity, and in case of the patient has connective tissue comorbidities, we don't recommend to use it, okay, based on our practice. The literature showed that after an implant surgery, a patient could have a pelvic pain, but in our practice, it is not common. And in our practice, the erosion, it's also not common. And if you see the confidence interval of vaginal wall erosion, it's very wide. It means that there are something different between the studies and between the centers. There are centers where the erosion is very low, and yeah, okay. And there are some centers where the erosion rate is very high. We should examine the reasons of the difference. You see, it's 9 to 21 confidence interval, which is quite wide, I think, and we should examine why it's wide. And this was the reason why we performed the second analysis to analyze the risk factors of the vaginal erosion, because there could be something, maybe the surgical practice, it could be. Yeah.
Okay. I would like to ask how many studies could you include in this multivariate analysis?
Here you can see the number of the studies. In case of the erosion complication, 20 studies included.
But this is the result of the multivariate analysis, right?
Yeah.
And so not all articles contained all the information?
Not all articles contain information about erosion, but contain information about another, for example, functional complications, or for example, efficacy parameters.
And all these studies were included in one combined multivariate analysis?
Yeah, but they weighted the number of studies.
What do you mean by that?
So, in case of only one study analyzed the buttock pain, it's a lower weight in the multivariate model, I think.
Okay.
But Peter Fehérváry made the multivariate model, and he told me it's very complicated, so don't start to detail this.
Okay. And all the studies that you included were what kind of studies?
It's mostly RCTs, randomized controlled trials.
So they are RCTs.
Yeah,
did you do
RCTs.
like a sensitive analysis for? Did you include also non-RCT, non-randomized trials?
Only in case of the univariate analysis.
Okay, but
we
not
have
here.
forest plots, not here. We have forest plots in the supplementary material, each complications about the univariate analysis, and it's contained to RCTs and observational studies also, but not put together in the multivariate model, only the RCTs.
And you list here lots of predictors. Some of, or many of them did not turn out to be significant. Did any of these surprise you? So was there any predictor where you expected a strong effect, but it turned out to be not significant, or the other way around?
Actually, pelvic pain, because maybe pelvic pain could be a complication why they ban this kind of surgeries, besides of erosion. Erosion is the most important one, but pain...
So erosion is something that you also expected?
Yeah, we expected erosion, exactly. And bleeding also, because it's associated with erosion sometimes. So this is why we perform the multivariate model, because there are associations in all complications.
And did you rerun the analysis with removing those which were not significant, or this is like the final model?
This is the final model, yeah.
Okay.
Yeah.
Tamás Vito from Szeged.
Yeah.
Congratulations
you.
For your excellent work and presentation. Just one thing I should mention, that the tables are hardly visible because the
very small,
and
sorry.
the numbers are too small.
Okay, sorry.
Maybe just for me, but other colleagues have better eyes.
Sorry.
So,
I would like to highlight the mean result above. This is why it's so small.
I don't want to ask you some methodological question, but very one practical question. There's a patient with POP, and there are several ways to operate her. And after explaining the benefits and risk of different options, would you recommend one distinct type of operation for a patient, or you would like to involve the patient in the decision?
It's based on the patient characteristic, the patient comorbidities, the stage of the disease, because the stage 4 prolapse we can treat more effective with the vaginal implantation. So it's based on the exact situation, but I think it's very important to discuss everything with the patients parallel and include experts who experts in the vaginal implant surgeries. For example, my supervisor is an expert in these surgeries, and maybe I recommend the patient to go him and operate, because it will be effective. Yeah.
Okay, thank you.
Thank you.
Judith Farga from the Department of Urology. Congratulations. These are very useful results for daily practice.
Thank you.
And I would like to ask you about your first topic. You highlighted that stress urinary incontinence after vaginal implant surgery is higher. And what is the reason this result?
Yeah, this could be the reason of the anatomically successful correction of the prolapse, because the prolapse can make a passive pressure to the urethra. And after, when we treat the prolapse anatomically perfectly, the hidden stress urinary incontinence will come with symptoms. So this is why we weigh these results. This could be the reason, I think.
Thank you.
May I have one more question to the third project? In the introduction, you mentioned that female urinary incontinence has a prevalence between 11.4 to 62%.
Yeah.
I think that needs some comment.
Yeah, because many types of urinary incontinence have not only, the majority of the cases is stress urinary incontinence, but there are a type of incontinences, and it varies a very wide age section, a very wide patient characteristic. So it depends. The population is very different with incontinence.
So for what population does the 62% apply?
For example, stress urinary incontinence occur in more obese women, for example, or women who had more labors, and this could be.
Thank you.
Madár István from gynecology department. Actually, I was wondering whether the post-operative stress urinary incontinence, urge incontinence will persist, or it is transient?
And the urge incontinence, it's normal. It's the same as before the operation. If the patient had, there are no statistical significant difference between and after the surgery based on the results.
Tavina, my question is, what are the risk factors of vaginal wall erosion that have been less studied?
Yeah, less studied the risk factors. Yeah, for example, the surgical practice. It's a very important risk factor, and nobody can analyze, because you can tell the patient you will be operated by an expert and you will be operated by maybe a junior. So it's very hard to examine. Maybe you can perform a retrospective analysis, and maybe this is the reason why our practice, it's a very low number of erosions, because in the urology clinic, 2 expert urologists who specialize to these implant surgeries perform all the operations. And it's, I think it's because of the higher number of operations and the good surgical practice, we have less erosion. But it's very hard to analyze.
Thank you very much.
Tomás Marton, Obszén Gynae Clinic. I've got 2 questions. One of, can you please explain to us why have they banned the implants at all? So what is the background behind it?
Yeah.
And then the second question that I would like to ask is about the functionality and any physiology as a treatment or conservative treatment. So where is the what are the indicators when you need to
do the surgery?
When you need to decide that it needs an invasive and an operative approach?
Okay, thank you. So regarding the first question, FDA issued the warnings because of the high number of erosion and because of the high number of pelvic pain after surgeries. And but it's based on a few studies, a few centers, and it was before these kind of surgeries make in the wide population. So maybe it was a little bit early restrictions, and for this you have.
So just relating to this. So these were rather old or historical publications based on which they decided.
Yeah, or maybe just too early to stop this kind of surgeries after the high number of complication, and they don't search the reason of the complications because they think that it's very dangerous. But I think it's not, but we could find the best indication and the patients who we can perform this surgery safety. And regarding to the second question, which was the functionality, before we perform all kind of surgery, we try the conservative treatment. And if the conservative treatment is not effective, or the condition is very, very serious and we can't see any chance to treat without surgery, we perform it. But based on not only one person decision, sometimes we tell the cases in the clinical referation. Okay, so maybe it's.
I would like to ask about the urinary tract infections. I would think that it occurs more, but is it because you use antibiotics, preoperative or intraoperative, or?
We use antibiotics preoperative, and we ask for help from the gynecologist also, and they examine the patient. And the patient has a symptomatic urinary tract infection. They treat before the surgery very correctly, because we don't operate in an infected vagina.
Thank you.
Good morning, András Rajka, PhD student. I'm quite amazed how big your population, I think, in your first study is.
Yeah.
It's over 1,000 patients. And my question would be how heterogeneous this population was from a clinical point of view. And if you think it was really heterogeneous, what do you think, how can a better grouping be done in the sense of to get more homogeneous population?
Of course, in case of a large population, the heterogeneity will be higher, but there were many RCTs, randomized controlled trials in the 77 study, and maybe it's a lower heterogeneity. But because of the different vaginal compartments, because of the different vaginal implant types, of course there is a heterogeneity, and we cannot eliminate all of them. We made the subgroup analysis also based on the vaginal compartments, and the article included, but during the practice, sometimes we do anterior and the posterior vaginal wall reconstruction in the same time, so it's hard to separate all operations in practice. So I think it's a natural heterogeneity of this study.
Thank you.